Okay, welcome to this video, another video in our series of simulations. In this video, we're going to examine a patient's shoulder. Okay, so what we're going to do is we're going to fire up our X-ray room. So we're going to fire up the X-ray room here. And we're also going to fire up the console. And we'll put our username in here. And sign in. Okay, so I'll make that large. Now, before we get involved with picking a patient to X-ray, we have to think about how we plan the procedure, and also because we're new novices, then we don't have a lot of information to our fingertips, so we're going to need to refer to some information. So what I've got here is two documents that you've already been given, which we'll look at. So the first one is the examination timeline table. So this is a really useful document and definitely something that you should have available to you at the moment. And it's something I could print off, put it into one of your textbooks. So really useful piece of information. So what we've done with this timetable is we've broken down the whole process of examining a patient radiographically into 9 separate activity sessions, 9 different lists of activities. Okay, and the first set is what we call pre-examination. Then we've got the actual time with the patient having the examination, and then the post-examination. So we're going to start this off with the pre-examination checklist. So we know we're going to x-ray a patient for a shoulder. So the first thing we've got to do is gather information. That means read the request. Justification, which means we've got to make sure that the request is justified, and assign staff and equipment. Well, we're the staff, so we need to think about the equipment and get all the equipment prepared. So this is the sort of thing that we need to do. So we'll start with this box here. Now, to do that box, what we need is this document. Okay, so this document is, we call it TERS. It's the Teesside University Referral Criteria for examinations. So basically, here we have it. So again, something that you should really have available to you. So what we're looking for here is upper limb projections. So upper limb examinations, section 2.5, they're on page 10. So we'll whiz down to page 10 and we'll find this stuff out. So where are we? 2.4, 2.5. Okay, so justification guidelines for upper limb exams. So let's go and find our patient, and then what we can do is we can compare. So we go to the modality work list, we pick our patient for a shoulder x-ray. So we're going to x-ray Patricia Bouveret-Swisher for a shoulder x-ray. So she's a javelin thrower, reduced active range of right shoulder movement, joint pain, query arthropathy, query Milwaukee shoulder syndrome. Okay, so let's look and see what the document says for patients referred with these sorts of conditions. So what it's telling us is that an arthropathy, which is a problem with the joint, Milwaukee shoulder syndrome would be an arthropathy. Then it tells us to do an AP of the affected area only. So that's the projection that's justified. So where some of the others are requiring more than one projection, this only wants an AP. Okay, so that's fine. And if we scroll down, then we get the exposure factor guidelines. And for a shoulder, it tells us that an AP should be something like AP should be 64 and 4 MAS. So a tube voltage of 64,000 volts and a tube charge of 4 MAS. And we should have a dose area product of less than 4 centimeters squared. Okay, less than 4. So let's have a look at that. So we're going to pick this patient. Now we know that information. The patient's walking, so we'll be able to do this standing up. So we'll click erect. And the projection that we want to do is the AP oblique for glenoid. Okay, so that's the projection we're going to do, because if we look at our referral criteria, the AP oblique 45 degrees to visualize the glenohumeral joint, and that's what we want to do because it's an arthropathy and we need to visualize the glenohumeral joint. Okay, so we're all set there. The exposure factors, we'll try this 64 and 4 as our settings, and then we'll go back to our exam list. So that was the information that we had. So now the next thing is patient preparation. Okay, so the stage here is about seeing the patient and getting them ready for the exam. Now, you don't necessarily have to do this bit. For things like a shoulder, you may do. So for a shoulder, what we might need to do is get the patient to remove some of their clothing because, bra straps can show up, necklaces, things like that. So sometimes we have to get the patient into a changing cubicle and change them into some sort of a gown, so that, and we do that at this stage. But mostly for exams which are, things like fingers, wrists, hands, then we don't need to do this stage at this point. We can do it in the X-ray room. So sometimes we do the patient preparation stage before, and sometimes we do it in the room. And we also have radiographic helpers, and radiographic helpers can work in the X-ray department and will usually do this stage for the radiographer. So they'll have already got the patient prepared. So this stage may not be something you're going to do. Or as a student, you may be doing this bit for the radiographers at the beginning without actually doing the exam. Okay, so next we're on to the radiography room preparation. So this is about making sure the machine is working, making sure it's tidy, checking that we've got all we need, selecting the study and the default exposures, we've already done that, and putting the tube in the right place. So let's get the tube and everything in the right place. So we're going to do the exam stood up against the erect bucky over here. So what we need to do is we need to move the tube over. Now we can do that manually. So I can grab hold of this and move it across, and we can rotate the tube as we have done previous weeks. But what I suggest we do is we go to the scenario menu and hit test stand. Then it automatically takes the tube over there to the chest stand. Okay, now I'm going to leave the tube a distance away, and I'll bring it in at the last minute to the patient, because it leaves a lot more space for me to stand with the patient and talk to them. So I'm going to leave the tube there for now. I'm going to bring my receptor into the picture, and what I'm going to do is I'm going to pick a 2430 8-to-1 parallel grid receptor. I'm going to drop that on the bucky there. So you may not have noticed, but it tells us here that we should apply a grid, and the source image distance will be 100 centimeters. So that's why I've picked a grid receptor. Now it's was it the right shoulder or the left shoulder? Can't remember. Go into the study tab. So yeah, it's a right shoulder. So I have to go back through all this again now. Always good to have a good memory. So 64, 64, and 4. So it's a right shoulder. So we'll go back, put a right marker on here. So if you imagine the patient's going to be facing you, so the lateral aspect of their shoulder is going to be over that way. So we'll put the marker there. So we're all ready to go. I want to blind the patient with the light, so I'm going to just drop that down and collimate to the size of the receptor. Obviously I'm going to be bringing this in, so it will have to change that again, but at least I'm not going to blind the patient if I turn the light on in that way. Okay, so I think I'm ready now. If I go back to my examination timeline, if this was the first exposure of the day, then I would be x-raying a test object just to make sure the machine's working as I expect it to be. We're going to assume that this isn't the first exam of the day. So we're happy that we've got everything we need. So we've done the first line. We've done all the pre-exam stuff, yeah? So now we need to move into the exam stuff. So this is where we re-identify the patient, confirm justification, gain consent, and do some hand hygiene. So we bring the patient into the room, and then, okay, so we've brought a patient into the room. So this is where we might talk to them and say, you know, I'm the student radiographer, you know, can you give us the first line of your address, all of those sorts of things. And we make sure that it is the right side that's hurting. Yeah, so we talk to her about that, what it is that's causing the problem, get a bit of a history. And what we're doing is we're just checking that the story fits with this clinical history. Yeah, making sure that it's not the other shoulder. It's not unheard of for patients to be written up for the incorrect side exam, etc. So we're happy that that all fits. So we can now carry on. So again, we're going to go back to our checklist. So what we're doing is we're actually getting the patient all set, whether or not we're checking all this stuff off. So now we're going to collimate to the desired place, find the centering point. So this is all in the procedure stuff. Yep. So here we go with centering beam, optimizing the collimation, all of that sort of stuff here. So, okay, so the centering point for this is actually the coracoid process. So we turn the patient not quite 45 degrees. So now this is a what's called a right posterior oblique. So get her in her position as we want. We then bring the tube into 100 centimeters source image distance. And then we raise this up to center at the coracoid process. Raise up the receptor again. And I'm going to open the collimation a little bit just to make sure I get everything I want on. And I'm going to bring the marker into the X-ray field. So I'm happy with that. I need to push her a little bit further back so that she's touching, because I know patients who are not touching anything will wander. Okay, so so I've told her what's going to happen. I've warned her about the noises the machine's going to make, etc. And she's aware of what's going to happen. So we now, obviously I wouldn't have my checklist, but we're looking at this. So we're happy with that. So we're now going to expose. So we've finished the procedure bit once we hit the expose button. So we hover over the exposure button, and when it goes green, expose. And here we have our nice image. Okay, so that's a very nice image. We've got our demographics on. So let's go back to our checklist. And let's look at our checklist now. So post-exposure. So reassure patient, offer explanation, clean and process receptor, repeat if image clearly not acceptable, document repeats, assist patient holding area clean and tidy, hand hygiene. So this is, we're happy that this is correct. So what we're going to do is we're going to discharge our patient. So we would talk to them, tell them where they're going next, ask them if they've got any questions, and discharge our patient. Now, we may just be putting them into the waiting area, clearing the room so that another radiographer can jump in and do an exam. So next, it's image evaluation. So we now need to make sure we've got adequate image viewing conditions, but now we're just going to go through the checklist. So first is demographic check. So is this Patricia Bouvier-Swisher's image? Because with these systems, it's possible that you can pull up the wrong image off the list and be checking an image which actually isn't for your patient. It's possible that another radiographer has x-rayed a shoulder, and that's the one that's come up on the list instead of yours. Markers and legends, we've got the right marker on and it's visible and it's clearly there. We did x-ray a shoulder and it was a shoulder that was asked for, so that was the anatomy. Markers, projection, it is quite a nice projection. We could have got a little bit more through the joint space here, so we might have repeated that, but not necessary, I don't think, in this occasion. We might try that again in another image just to see what it looks like. It's not ideal, but I think it's reasonable. Structures shown. So we have the acromion process of the scapula, we have the clavicle, we have the coracoid process of the scapula, we have the glenoid cavity of the scapula, neck of scapula, lateral border, superior border, where we've just got the suprascapular notch there. So very nice. We've got some ribs showing up here. Here's our humeral head. We've got a greater tuberosity and our lesser tuberosity, which is just here. We've got the anatomical neck, which goes from there to there. And we've got the surgical neck, which goes from here to here. And we've come down here and we're just starting to see the deltoid tuberosity in the shaft. So yeah, we've got all we need. We've got soft tissues. We can window to see soft tissues to see if there's any calcium in the tendons. Yeah, that's nice. Okay, so go back to our checklist again. So evidence of collimation. Yes, we've got 4 collimation marks, so that's good. Image quality. So we're looking for the 4 signs of image quality. So we're looking for bone, which we can see. We're looking for fat. So we're looking for a dark layer, dark stripes of fat, which you can just see here. So these are the fat lines. We're looking for soft tissue, which is the lighter grey. And we're looking for air, which is the black here. So we can see all those. We're looking to see if there's any noise in the image, which there isn't. I keep clicking it, sorry, this keeps disappearing. So there's no noise, we've got relevant contrast, there's no distortion, there's no artifacts, so there's no chains. This would be where you'd got a bra strap here or a chain or some such thing that might be, distracting. Protection, so we're looking for the exposure index here now. So the exposure index is 136. So this is a little bit low. We would like something around 250 for these exams. So that's a maximum though, 136. Well, it's not a maximum, it's an ideal. We don't really want to go 20% more than that or 20% below that. So this is a little bit low. So I might be tempted to repeat it to get my exposure index up. So we could call the patient back in and do another image with a double the exposure index at a 136. If we doubled it, we doubled the MAS to 8, then we'd get an exposure of 260 odd. It works linearly with the MAS, which would be about ideal, really. So we might bring her in. That and this combined would indicate that it's probably worth doing this again. So we might bring her back in, turn her a little bit more, and add up the MAS to a higher number to get a little bit more. The fact that this is low means the image quality is not as good as it could be. Okay, clinical history. So we go to the clinical history now, and bring the history back up. And then what we do is we look for, if I bring this back up here, we look for alignment, bones, cartilage and joints and soft tissue. So this is the, what we're now looking to see whether we can see any of the problems that were requested us to look for. So can we see an arthropathy? Is there anything in the joint there? So that's the joint bit. Bones, are the bones all regular? I'm not going to go through this in any detail because this is the first time we've been talking about this. But basically, we look for the bones. We look for alignment of joints to make sure that everything's lined up. We look to see whether the joint space is maintained and whether it's got anything in it, whether it's too narrow or too wide. And we're looking for soft tissue, swelling, and things like that. So that's why we do there. Okay, so I've done all that. We're now doing the case review. So what's my decision? My decision is that I'm going to repeat this. I'm going to turn the patient a little bit more, and I'm going to double the MAS. Okay, so that's what I'm going to do. I'm going to make a repeat. I'm not going to discharge the patient. So carry on and repeat this. So we're going to do the AP oblique. So go down to 65, but this time we're going up to 8 because we know that the exposure wasn't quite right. Okay, so now we go back into the room. We bring our patient back in and explain to them that we need to do another image. Now, obviously, the patient can sometimes say, why? Why? Is it something, serious or anything? So you have to reassure the patient again. So I'm just turning her a little bit more steeply this time than I had before. I have to sort of memorize where I had her before. And that's fine. Everything else is the same. And hover over and hit the expose button. Expose that. And here we have better image. So the exposure index is now 255, which is bang on. And you see where we couldn't get through the joint space before, now we're through the joint space nicely. So it's better and easier for us to make a decision about whether or not there's anything in that joint. Now, let's just have a look and see what I think, if I'm right, I think Milwaukee shoulder syndrome is something to do with crystalline destructive. Oh, it's okay. So it's a. I think you get depositions, calcium depositions in the joint. So yeah, so you can see that this joint here is completely collapsed. You see, if we had Milwaukee shoulder syndrome, this is what we would expect to see. Whereas what we've got is a nice clear joint space. So I think this is, although there is, I'd have to say that this doesn't look as smooth as it could. So anyway, we've got the information for the experts to have a look at, and I'm sure the orthopedic surgeon's seen more of these than I have. So I'm happy that this gives him the information he needs, or her, and we'll discharge our patient again. And this time we can send the patient to go home. So that's fine. And then what we maybe do is I'll go back here, scenario, and go floating table. So leave the tube in the default position where you left it. Okay, so and I'm go back to our timeline, and it tells us that we document the exam on the radiology information system, archive exam on PACS, and take responsibility to discharge the patient. So we've completed our exam. So there you go. So that's what we're doing today. We'll X-ray the other shoulders, and we'll look at some extra. We might look at clavicles and some other reasons, other ways of doing shoulders.